Assalamu alaikum. The topic of today's discussion is bladder extrophy and Epispadias complex. Dr. Mara will be presenting the topic.
Assalamu alaikum everyone. My topic of presentation today is bladder extrophy and Epispadias complex. The learning objectives of today's presentation will be the definition, embryology, and the etiology, the associated anomalies with the EEC, and the surgical approaches, along with the goals associated for the EEC. First of all, we are going to discuss the embryology of the EEC. That the diagram is showing the normal embryology of the cloaca and the cloacal membrane, which showed that the caudal descent of the urorectal septum divides the cloacal cavity into the urogenital sinus anteriorly and the rectum posteriorly. The breach in the normal embryological development will result in the development of the EEC, which occurs due to the failure of the ingrowth of the mesenchymal tissue in the cloacal membrane. Along with that, there is premature rupture of the cloacal membrane. There are various theories associated with the embryological development of the EEC, one of which is Marshall-Mack theory, which states that abnormal overdevelopment of the cloacal membrane during 4th week of gestation. It prevents the medial migration of the mesenchymal tissue, and there will be the failure of the lateral body wall force to meet in the midline with abnormal fusion of the genital hillocks caudal to the cloacal membrane. Risk factors associated with the EEC is the increased maternal age on average 24 years, increased smoking during the first trimester, and the high doses of the progesterone taken by the mother during the first trimester. And there is, and with the in vitro fertilization, there is around 7 to 10-fold increased risk. The genetic association is with the mutation in the genes of CASPR3, that is present on the chromosome 9 desmin and P63. The patients with the family history of the EEC has a risk of recurrence 1 in 100, 1 in 100. That there is increased risk in the patient with the positive family history of the EEC. Basically, the bladder extrophy is the spectrum of anomalies that involves the musculoskeletal defects, including pelvic bones, abdominal wall, pelvic floor, and urinary defects, genital defects, and the anorectal defects. We're going to discuss each of them separately. First of all, we are going to discuss the musculoskeletal defects that involves the bone pelvis and the spinal defects. These defects are include the dimensional anomalies and the rotational anomalies. In the dimensional anomalies, there is an increased pelvic diastasis or 5 centimeter or above it, shortened anterior pelvic centimeter around 30% and 30% increase intertriradiate cartilage distance. The rotational anomalies include the external rotation of the anterior and the posterior pelvic segment, 10% coronal rotation of the sacroiliac joint, 15% inferior rotation of the bone pelvis, acetabular and femoral retroversion, conversions of the iliac movements. These rotational anomalies results in the short pendular penis and the waddling gait. Pelvic floor defects include anomalies of the levator ani, which normally forms the pelvic floor. In the normally, the levator ani is present 50% anterior to the rectum and 50% posterior to it. In the cases of EEC, the levator ani muscles is located 68% posterior to the rectum and 32% anterior to it. It is less dome-shaped with and more irregular. There is 15 degrees external rotation and 15 degrees external rotation of the levator ani, with the 30% being more flattened in the cases of EEC.
Normally, back slide पे जाइएगा. Normally the levator ani muscle is in normal condition. The 50% is anterior to rectum and almost 50% is posterior to the rectum. Okay. In this case, the majority of the levator ani muscle goes posterior to the rectum. The function of levator ani is a part of sphincter mechanism, and when it goes posterior to the rectum, there is the disbalance in the sphincter mechanism, and it leads to incontinence too.
Yes. The abdominal wall anomalies include the triangular defect that occurs mainly due to the premature rupture of the cloacal membrane, and that defect will be occupied with the extrophy bladder and the posterior urethra. The anterior sheet of the rectus muscle has a fan-like excision that inserts behind the urethra and the bladder neck into the intrasymphysial band, and the distance between the umbilicus and anus is short. There will be the frequent occurrence of the indirect inguinal hernia due to weak abdominal wall and the large internal and external inguinal ring and the loss of obliquity of the inguinal canal. Rarely, the umbilical hernia, small umbilical hernias and imphaloses are also seen with the abdominal wall defects in EEC. Anorectal defects include the displacement of the anus anteriorly. 2% of the colorectal anomalies associated with the EEC include imperforate anus most commonly. Other two are the rectal stenosis and the rectal prolapse, as Dr. Daniel previously said that the levator and is associated with the containing mechanism of the rectum. So if there is any abnormality in the levator and muscle with the divergent puborectalis muscle and the distorted anatomy of the external sphincter, it will result in the anal incontinence and the rectal prolapse. The male genital defects associated with the EC include a 50% shorter anterior corporeal length with 30% greater diameter, and the urethra lie anterior to the posterior. Most of the prostate does not lie circumferentially around the urethra, whereas the weight, volume, and the cross-sectional area of the prostate is normal. The breast deferens, ejaculatory ducts, and the seminal vesicles are normal. The scrotum is flat and wide, and there is a frequent finding of undescended testes, which are usually retractile, and the patient can be benefited well without the archidopexy after the primary care. This is the picture showing the male genital defects with the exposed bladder, short stubby urethra with exposed urethra plate, and the flattened, well-developed scrotum. Female genital defects include the shorter vagina that is of normal caliber and the stenotic vaginal orifice that is displayed and that is displaced anteriorly. Defect clitoris, the labium, bones, pubis, and the clitoris are divergent. Fallopian tubes and ovaries are usually normal. Urinary defects include the bladder polyps, fibrous or edematous associated with the squamous metaplasia in 50% of the cases, cystitis glandularis, and there is an increased risk of adenocarcinoma, which is seen in 8% of the augmented bladder, and this can be followed in the adulthood by the psychological examination of the urine as well as by the cystoscopies.
Okay, can anyone tell me what is cystitis glandularis? It is basically the metaplasia of the bladder mucosa. Normally, bladder has a transitional epithelium. In this condition, the glandular metaplasia occurs. So the epithelium is replaced by glandular epithelium, which is usually due to chronic irritation and inflammation of the bladder. It can also occur in the adults due to other conditions like UTI, recurrent UTI, or other irritative symptoms of the bladder. It is basically a benign condition, but there is increased risk of adenocarcinoma in this situation.
The viewer is seen in 100% of the cases with the close atrophy, and it is one of the reasons that the urethral reimplantation is performed at the time of the bladder neck reconstruction in the cases of surgical correction of the EC. So there is a long debate regarding the development of the normal neurological development of the bladder after the surgical correction. So in the cases are observed where there is no difference was found and there is no evidence of bladder muscle denervation, and there were normal receptors and the nerve fibers in the patients with the EEC bladder and those in the controls. This is the diagram that is showing the polyps over the bladder mucosa, edematous, and the fibrotic. Upper urinary tract anomalies are usually rare, but malformations can be present, which include most commonly duplicated collecting system, hypoplastic absent kidney, and the pelvic kidney, uteropelvic junction obstruction, and multicystic dysplastic kidney. There are some variant defects that are associated with the EC, one of which is silver extrophy. In this case, there is the presence of the musculoskeletal defects without the major urinary tract anomalies. There is the presence of the superior vesical fissure. The superior vesical fissure occurred due to the rupture of the early rupture, premature rupture of the cloacal membrane at the uppermost portion, and this superior vesical fistula resembles a vesicostomy. And the third is the covered extrophy, in which the bladder template is covered by a thin membrane of the lower abdominal skin. And fourth is the duplicated bladder, which is of two types. One is anterior posterior, and other is side by side duplication. The anterior posterior duplicated bladder, in anterior posterior duplicated fashion of the bladder, the one bladder template is seen externally in the extrophy defect, and the in the side by and other bladders seen in the panels. And side by side duplication, there is left to right there is left to right orientation of both the bladders with the complete muscular septum between them. Both of them have the separate sphincter mechanism as well as ureters. This is a picture showing the superior vesical fissure that is occurs secondary to the premature rupture of the cloacal membrane. This is the covered extrophy. You can see the thin membranous skin present over the bladder template. Okay, and the EC can be diagnosed initially in the 25% of the cases, and the ultrasound findings that we can see that can be seen are the absence of the bladder filling, widening of the pubic venous delimiter of genitalia, and the abdominal and the lower abdominal mass, which is basically the viscera coming from the triangular defect that increases in size with the progression in the pregnancy. Management at birth include the umbilical cord is tied with the 206 suture close to the abdominal wall in order to avoid the application of the clamp for which can irritate the bladder and can result in the development of the edematous and the fibrotic bladder polyps and the development of the metaplasia. And the bladder can then be covered with a non-adherent film of plastic wrap. Surgical reconstruction basically involves two major procedures. One is the modern stage repair of the extrophy, and other is complete primary repair of the extrophy.
Okay, these are two different approaches in the management of extrophy epispadias complex. In the modern stage repair of extrophy, we do staged repair. In one stage, we close the bladder. In the second stage, we repair the epispadia. And in the third stage, we reconstructed the bladder neck at different ages of the patient. In complete primary repair of extrophy, we do bladder closure as well as epispadias repair at the same stage. There are certain benefits as well as disadvantages of these different approaches. The benefit of complete primary repair is that at the earlier, it is done usually at the earlier age of the patient, usually within the 72 hours. The benefit occurs that when we we repair the epispedia, there is increased outflow resistance of the urine, which cause bladder recycling in the bladder, and bladder capacity improves with age. While the second benefit is at the earlier age, like within the 72 hours, the pelvic bones of the patient are flexible. It is due to the presence of a hormone relaxin from the mother, which increase the mobility of the pelvic bones of during the delivery. Within the 72 hours, this hormone is present, and there is increased flexibility. And during repair, the repair can be done without osteotomies. While when we do the repair at the later ages, like 4 to 5 months, as in stage repair, the bones should be approximated by using this osteotomies of the pelvic bones. The benefit of staged repair is that at later age, there is increased growth of the bladder template, and the bladder is somewhat matured, and the increased visualization of the tissues, and there is also somewhat less risk of anesthesia at the later ages as compared to within 72 hours. So these are the two different approaches Dr. Mara will be discussing.
The goals of reconstruction will be the principal objectives will be the achievement of urinary continence, volitional hardening, low pressure urinary storage system, preservation of the kidney functionally and cosmetically well external genitalia. The secondary objectives for the surgical reconstructions include avoidance of the urinary tract infection, reduce risk of urinary calculi, minimize the risk of malignancy, and preserve integrity of the abdominal wall fascia and the preserve integrity of the pelvic floor. As told by Dr. Daniel earlier, that the need of osteotomy is needed when the bladder report is done after the 72 hours of the age because of all the hormonal association relaxin that I've already told. So the osteotomy either performed prior to the primary closure at the time or at the time of the primary closure of the reconstructive procedures. Indication of the osteotomy include when bladder closure performed after 72 hours of age, non-malleable pelvis and the pubic diastasis more than 4 centimeter. Types of osteotomy are bilateral osteotomy of the superior pubic ramus, diagonal osteotomy of the iliac rim, anterior innominate osteotomy with or without vertical iliac osteotomy. Advantage of the pelvic osteotomy at the initial closure include easy approximation with diminished tension on the abdominal wall closure, placement of the posterior vesical urethral unit deep within the pelvic rim, and it allows the anterior movement of the levator ani to strengthen the puborectalis muscle. The complications associated with the osteotomy is inadequate immobilization, failure of closure, bladder prolapse, loss of suprapubic tubes and urethral stents, pain, lateral femoral peroneal nerve palsy that can be transient, delayed iliac union and non-union leg length inequity, infection, osteomyelitis, skin site infection, and pressure sores. This is modern. There are three different stages of the modern stage repair of the extrophy. The stage one is usually performed within 48 to 72 hours of the birth in both boys and girls. In the girls, the concomitant Epispadias repair can be done along with the primary closure of the bladder and the abdominal wall. The iliac osteotomies can be performed at this time. Stage two involves the Epispadias repair that is usually performed at the age of 6 to 12 months in a male child. Stage three is consisting of the bladder neck reconstruction. It is usually performed at the age of 4 to 5 years, and along with the bladder neck reconstruction, the bilateral uterine reimplantation is done. It is performed when the child can participate in the warding program and the child has achieved the adequate bladder capacity.
Okay, why we do bilateral uterine implantation at the time of bladder neck reconstruction? Okay, while reconstructing the bladder neck, we usually need a more space because in this condition, the UOs ureteric orifice are near to the bladder neck. And we need some space to close the bladder neck. And when the UOs are more near to the bladder neck, these can be easily damaged or come into the sphincter mechanism. We reimplant it more superiorly so that there is more space available for reconstruction of the bladder neck and avoid injury of ureteric orifice.
And one more reason is to avoid the VUR that is seen in the 100% of the cases after the primary closure. That's why we perform uterine implantation along with bladder neck reconstruction. Okay, and this is the pictorial representation of the stage one modern stage repair of the extrophy, and it includes the primary closure of the bladder and the abdominal wall defect in the patient with the EEC. Initially, the incision is given following the bladder template, proximally involving the umbilicus, and distally it involves it extends up to the mid shaft in the boys and up to the vaginal os in the female child. Dissection of the lateral aspect of the bladder from the abdominal wall is done, and the stents and suprapubic tubes are placed in the bladder, and the urethral meatus is calibrated to 14 French size. Stents are brought out of the bladder, and the bladder closure is done. Abdominal wall is closed in interrupted fashion, and the suprapubic tube and stents are brought out through the new umbilicus. Stage 2 is the Epispadias repair in the modern stage repair of the extrophy. And one of there are different approaches to it, which is cantilever wrestler repair, modified cantilever wrestler repair, Mitchell repair. Here we are going to discuss the modified cantilever wrestler repair that is most frequently performed. The goal of the Epispadias, and it is usually done at the age of 6 to 12 months, and the goal of the Epispadias repair include the correction of the dorsal cording, nasal reconstruction, glandular reconstruction, and the penile skin closure. In this approach, first of all, the dissection of the foreskin is done on the ventral aspect of the penis. The corporas are dissected on the urethral plate and the parallel incisions are made into the glands to create the gland sphinx. The urethra is tubularized using a continuous running sutures over a urethral stent, and the corporas are approximated above the urethra to provide an anatomically ventral location of the urethra. When we approximate the corpus over the urethra, it results in the layman term, we can say that it will bury the urethra, giving it the more ventral position. Then the gland slings are closed over the glandular urethra, and the gland's epithelium is closed. Ventral skin is brought up fashioned to provide adequate coverage and lengthening of the dorsum of the penis and reapproximated with interrupted sutures. Thus, foreskin is also sutured to the ventral edge of the corona. Silicone stent is left indwelling in urethra to provide the drainage for 10 to 12 days.
Yeah, so this is the restoration of the normal anatomy of the male genitalia. In Epispadias, everything lies in front of the like urethra is lying in anteriorly to the corpora. So we have to get it posterior in the normal anatomical position and restart the anatomy.
And the third part of the modern stage repair of the extrophy is the bladder neck reconstruction that can be performed by the different approaches, one of which is modified Young-Dees Ledbetter and the Mitchell repairs. And it is performed in the incontinent children after the complete primary repair of the extrophy or the modern stage repair of the extrophy. A continent procedure is indicated when the urethra is structure-free and capable of catheterization. Under anesthesia, the bladder capacity should be minimum 60 to 85 cc, and a child is mature enough to participate in the post-operative wedding program. Usually at the age of 4 to 5 years, the bladder neck reconstruction is performed. This is now I'm going to define the modified Young-Dees lead bladder technique for the bladder neck reconstruction. First of all, the skin incision is given, extending from the umbilicus to the base of the penis. Then the vertical bladder incision is given with distal transfer extension, where the bladder and the posterior urethra are under the pubic bar. Ureters are identified, and the ureters are identified, and the urethral stents are placed into the ureteric orifices and are sutured to the mucosa. Then the ureters are mobilized and reimplanted in the cephalotrigonal position. The segment of the triangular mucosal strip is excised on either side of the median strip, measuring around 1.5 into 3 centimeter, that will form the new urethra. Short incision is given in the muscle that will permit the extension of the bladder neck. Urethra is tubularized using a continuous running sutures. Posterior urethra and the bladder neck is reconstructed. Bladder muscle is brought together. That the bladder muscle, that is the part of the triangular dissection of the flap, they are brought together in the double-breasted fashion over the new urethra. Then the vertical incision that was given over the bladder is closed in the interrupted fashion, and a distal suspensory sutures are tied over the abdominal wall, and the pubic tubes and stents are left in place. After bladder neck reconstructions, At the end of the 3 weeks, suprapubic tube is clamped and patient is allowed to attend the ward. The clamping and declamping thing that we have all seen, most of us. Usually, initially, the suprapubic tube shouldn't be clamped for more than 1 hour. And if the child can empty satisfactorily, the SPC is removed. Frequent bladder and renal ultrasound are required in the first few months after the bladder neck repair. Now I'm going to discuss the second approach for the reconstruction of the EEC, that is complete primary repair of the extrophy. The objective for this is to combine the bladder closure and formal epispadias repair at the initial reconstruction. Traditionally, it is performed at the 72 hours of the birth. Main difference in that is that the initial incision, the complete primary repair of the extrophy is carried onto the urethral plate as the part of planned concomitant epispadias repair. The Epispadias repair follows the Mitchell technique or one of the several of its modification. This is the Mitchell Penile disassembly for the Epispadias repair in cases of in the approach in complete primary repair approach of extrophy. In those, the penis is dissected into the three components, the right and the left corporus and their associated hemiglands and the urethral wedge. Urethral plate, the dissection moves medially just above the buccal fascia, taken down to the tunica albuginea of the corporus. Care is taken to preserve the spongiosum with the urethral wedge, and this dissection is carried posteriorly to the area of the bladder neck. The urethral plate detached from the glands and the urethra is brought out between the corporus to a hypospadiac position. Corporas are then positioned into the midline with interrupted suture. Skin is closed with fine absorbable suture. This is how we can restore the normal anatomy in by the Mitchell Penile disassembly with the complete primary repair of extrophy. The one potential benefit for this approach is attaining the earlier appropriate bladder outlet resistance, facilitating bladder cycling at younger age, and optimizing potential for the bladder growth and development. The recent shift I have seen with the delayed complete primary repair at the age of 2 to 3 months of age. The potential benefit that it gives is the somatic growth of the organ system development, which reduce the risk associated with general anesthesia. Another benefit is seen is the endogenous testosterone surge that occur in the first several months of the life in boys to for the penile growth. And the downside of delaying initial repair is the posterior need of the posterior iliac osteotomies, because the pelvis will become less malleable, and there is potential for the reduction of the bladder mucosa and the development of the squamous metaplasia. The children who are going complete primary repair of the extrophy may remain incontinent and may later require bladder neck reconstruction, at which time the uterine reimplantation can also be performed. Post-operative care after primary closure include the post-operative immobilization, use of post-operative antibiotics, care of uterine standing catheters, advocate post-operative pain management, avoidance of abdominal distension, advocate nutritional support, and secure fixation of the urinary drainage catheters. Post-operative immobilization can be achieved by the different techniques, and the patient remains supine in traction for 4 weeks. And the post-operative immobilization can be done by the mummies wrap, spica cast, modified Bryant's traction, in which the hip are flexed at 90 degree, modified Buck's traction with osteotomy, and by the external fixator devices. In follow up, the bladder outlet is calibrated by urethral catheter or the urethral sound. The suprapubic tube is removed after 4 weeks, and the complete ultrasound at 6 months to 1 year interval is needed. Urine cultures are performed, and cystoscopy and cystography is done at early interval. On the cystoscopy and the cystography, if the bladder has not achieved a capacity of 30 ml by 1 to 2 years, concerned about overall ability of the bladder to undergo continence procedure, and should be concerned about. And if the bladder outlet resistance persists and infection continues, the anti-reflux procedure should be done as early as 6 months to 1 year after the initial closure. One of the approach for the bladder reconstruction in EEC is the Kelly repair. It is a multi-stage repair in which the radical soft tissue mobilization is done with the closure of the bladder dome and the hernia repair at birth. The reconstruction of the proximal urethra with associated sphincteric tissue, along with penile lengthening and the creation of the penoscrotal urethrostomy, is done at the age of 3 to 6 months, and then repair of the resulting penoscrotal hypospadias is done at the age of 3 years. The complications associated with the reconstructive procedures include dehiscence of the fascia, vesico-cutaneous fistula, bladder prolapse and dehiscence, significant loss of soft tissue of glands, ischemic loss, incontinence, post-outlet obstruction, urethral structure, suprapubic tube removal, intrapubic stitch erosions, febrile UTI, wound infection, bladder spasm, and the bladder calculi. Okay, there are some cases in which the primary closure is unsuitable in the newborns, and the cases involve the patients with the hypoplastic bladder, in which there is small and fibrotic bladder patches present without elasticity. Because in these cases, if we perform the primary closure, the bladder is unlikely to be developed after the closure because of the less elasticity in the bladder template. The penoscrotal duplication ectopic bowel within an extruded bladder and a significantly bilateral hydronecrosis. In the cases of the hypoplastic bladder, we should wait for the bladder template to grow for 6 to 12 months. And if it does not grow to the sufficient size after 6 to 12 months, the alternate procedures can be done, which includes the excision of the bladder with the development of the non-refluxing colon conduit or the ureterosigmoidostomy. The adjunct procedures are performed in the children who have the poor bladder capacity or the poor bladder compliance, and in those who fail to achieve the continence or safe bladder storage characteristic following bladder neck reconstruction. And these adjunct procedures include augmentation cystoplasty, which can be done by either iliocystoplasty, sigmoidocystoplasty, right cholecystoplasty, means cystoplasty, and the gastrocystoplasty, as well as ureterocystoplasty. Catheterizable conduits can be made, which is Mitrofenov, Yang-Monty, iliovesicostomy, and the ureterosigmoidostomy. As I previously said, that the ureterosigmoidostomy is done in children in whom the modern repair is not an option. Those with the small bladder plates, and in those who have had failed the extrophy repair. This is the chart that is summarizing what we have previously discussed in the modern stage repair of the extrophy. And it describes the timeline for the extrophy reconstruction along with the early follow-up of the child with the cystogram and the cystoscopy. At the birth, the intervention performed the bladder closure, and the considerations that are kept in mind is to assess the bladder plate, its condition and the size, and to consider if there is any need of osteotomy or not. At 6 months, the Epispadias repair is done, and the assessment of bladder capacity is made. Up to 2 to 4 years of age, the upper tract should be monitored for reflux and infections. So, up to 5 to 7 years of age, the bladder capacity is assessed with the urodynamics and the child's ability to participate in the boarding program. Once the patient has achieved the adequate bladder capacity and the ability to participate in the boarding programs, the bladder neck reconstruction can be done. Thank you so much.